Once you detect that there is a significant level of jaundice, we treat the jaundice with phototherapy. I have a short video on phototherapy and how it works, but in short, phototherapy is basically blue light, which is light in the wavelength of 430 to 490 nanometer micrometer. And previously we used to say keep at least 45 centimeter, but now that concept has changed. We have LED lamps, we have the Billy beds, and we have the Billy blanket, so they can be very close to the surface of the baby. The closer it is, the higher the irradiance, which is a factor which determines how effective the phototherapy is. So we have the baby under phototherapy. You have LED units with different irradiance, but there is not much point in using a milder type of phototherapy. You want to keep the phototherapy at maximum efficacy so that the duration is shortened. There is a difference in the extreme premature babies, however. There the higher irradiance has a tendency to cause oxidative stress, and so we may have to start with a single phototherapy and then increase intensity only if needed. But in the bigger baby, start with intense phototherapy and keep it for a period of time that you need till the bilirubin comes down, and then take the baby off and monitor again. So phototherapy involves little stress and anxiety to the parents. In some cases, if you need intensive phototherapy, like the level is approaching exchange level, you need a Billy bed. You may have to either move the baby away from the mother to the NICU or keep the baby in the Billy bed in the bedside of the mother. This provokes anxiety. So obviously don't give phototherapy more than what is needed, and there are some reports that phototherapy may not be totally safe. Of course, we believe it is safe and it's useful, but we need to use it only if needed. Again, you have the phototherapy charts. The American Academy has recently updated the guidelines, which shows that you can use a relatively higher threshold in the more stable babies. So again, it goes against very aggressive phototherapy. I told you that in the extreme premature babies, we may start with the lower intensity, but in the more mature babies with a higher level, you start with intensive phototherapy. That doesn't mean you go for a Billy bed. A Billy bed is more intensive, and it separates the mother and the baby more. So you need to use that only in the babies where it approaches exchange level. The American Academy has given definitions for escalation of care and how you intervene. Of course, this is a different topic and I'm not going to discuss that. Phototherapy, I mentioned it's blue light, and it works by modifying the structure of the bilirubin so it's in a more readily excretable form. So it kind of bypasses the need for the liver maturation, and it adds one step where the bilirubin is excreted in the urine quicker. It also changes the structure of the bilirubin, so it's less likely to cross the blood-brain barrier. So we have two benefits, and the benefit starts almost immediately within a few hours of starting the phototherapy. One of the ways to monitor is doing a blood test, because once you're under the phototherapy, the skin test is not going to be effective. The transcutaneous bilirubinometry is not going to be reliable. So we need a blood test. Once you know that the trend is coming down, you don't need to keep repeating that frequently. So 12 to 24 hourly repeat samples is adequate. And if the level is significantly lower, you don't necessarily need to keep the patient in hospital. After you stop the phototherapy, we can discharge them and bring them back the very next day. Proper patient education is very important to ensure that they understand, they follow up adequately. So they need to understand the importance of adequate feeding, regular feeding, supporting the feeding maybe by using a breast pump to express and make sure the milk is removed. Many parents ask the question of sunlight, whether it is useful. So the answer is that sunlight does have a slight benefit, but it should not deter us or distract us from the actual need to review in the hospital to make sure the jaundice is not increasing, and it doesn't have any role as treatment. Obviously, the reason phototherapy was discovered was this serendipitous discovery by NICU in UK, where they discovered that the babies who were near the windows had lower level of jaundice. So sunlight does benefit, but make sure that the parents are not falsely reassured and they delay follow-up or something like that. So there is another important concept in jaundice called prolonged jaundice, where if the baby is jaundice beyond 2 to 3 weeks, so previously we used to say test it at 2 weeks, but if you have a direct bilirubin tested earlier and the baby is breastfed and it's a term baby, we wait till 3 weeks. The same in premature babies as well. In a formula fed baby, we have to test it by 2 weeks if the baby is still jaundiced, because jaundice, persisting jaundice is not as common. The reason we test for the prolonged jaundice is not to miss out biliary atresia, which is a dangerous condition. You get higher level of conjugated bilirubin, in this case a direct bilirubin, and in that case you have to screen with an ultrasound and other tests, which I'm not detailing. So the reason we do the prolonged jaundice screen is not to miss a serious condition like biliary atresia. Of course, prolonged jaundice is common in breastfed babies, and I explained the bilirubin, the glucuronidase enzyme, which may be present in the breast milk and some others, and this recycles the bilirubin more. So once you know that the direct bilirubin is normal, the stool color needs to be yellow as well. A pale stool is not right, and a pale stool indicates a bile secretion is reduced, which may go in favor of a liver problem. So if you have no pale stools, the stool is yellow and the direct bilirubin is normal, you can reassure and continue to monitor. Another important point in prolonged jaundice is that the thyroid function should have been evaluated previously. Even if the newborn screening is normal, if the jaundice is significant at 3 weeks, better to add a thyroid function, including the TSH and the T4, so that we don't miss central causes of hypothyroidism. So this is a quick overview of jaundice, and obviously I have not discussed exchange transfusion or immunoglobulin. You can refer the American Academy guidelines, which I mentioned. I hope this format is useful. Do share with your colleagues and invite them to subscribe as well.